Hello everyone, welcome back. Today we are going to cover regarding acute hematogenous osteomyelitis AHO in children part 2 video. In this video, we started off with an X-ray findings in acute hematogenous osteomyelitis, the management of acute hematogenous osteomyelitis, the differential diagnosis of acute hematogenous osteomyelitis, and additional exam question in my final year. X-ray changes in acute osteomyelitis. This is taken from Apply textbook. During the first week after the onset of symptoms, the plain X-ray will show no abnormality of the bone. The displacement of the fat planes signifies a soft tissue swelling, but this could be due to a hematoma or a soft tissue infection. By second week, there may be a faint extracortical outline due to periosteal new bone formation. It is a classic X-ray of early pyogenic osteomyelitis. The late sign in X-ray that we could see is the periosteal thickening, patchy rarefaction of the metaphysis, right features of bone destruction will appear, combination of regional osteoporosis with a localized segment of apparently increased density. This X-ray of right knee shows an osteolytic lesion in the proximal tibia region. Okay everyone? Regarding the treatment of acute hematogenous osteomyelitis, in 1983, Need from Australia proposed a 5 principles for the treatment of acute hematogenous osteomyelitis. Number 1, an appropriate antibiotic will be effective before pus formation. Number 2, antibiotics will not sterilize avascular tissue or abscesses, and such area require a surgical removal. Number 3, if such removal is effective, antibiotics should prevent their reformation and therefore primary wound closure should be safe. And number 4, surgery should not further damage already ischemic bone and soft tissue. Finally, number 5, antibiotics should be continued after the surgery. The treatment of acute hematogenous osteomyelitis. It involves appropriate antimicrobial therapy in all cases and may require surgical incision and drainage. IND should be performed whenever an abscess, either intraosseous, subperiosteal, and/or soft tissue exists. Surgical removal of devitalized bone and debridement of affected soft tissue should be undertaken. Surgical drainage should be considered when a child does not respond to empiric antibiotic therapy. Regarding the length and route of treatment, although osteomyelitis has traditionally been treated with 4 to 6 weeks of antibiotics, studies supporting a shorter treatment times are emerging. A prospective study by Jagotskin et al. I'm sorry if I'm mispronounced. 2009, they found out that 59% of patients could be converted to oral antibiotics by 3 days and 86% by 5 days. Patients who are converted to oral antibiotics by 5 days receive an additional 3 weeks of oral therapy. The mean in-hospital treatment time was 5 days. There were no complications at 1 year follow-up. A randomized control trial, RCT, done by Peltola et al. 2010. Patient was treated with 2 to 4 days of intravenous antibiotics followed by 20 versus 30 days of oral therapy for acute osteomyelitis. The conclusion is there is no difference were found amongst the treatment group, and the author recommend that 20 days of oral antibiotics is sufficient, provided there is clinical improvement and C-reactive protein is normalizing. For antibiotic selection, patient is started on empiric antibiotic as soon as a joint or bone specimen has been obtained and sent for analysis. Empiric antibiotic therapy is selected to cover the most likely pathogens, which are determined primarily by local prevalence of infectious agents and resistance levels, the age of the child, and early laboratory results such as gram stain, if available. Selecting a cephalosporin that covers the methicillin-sensitive Staph aureus (MSSA) and Kingilae is typical. This figure illustrates an algorithm for suggested initial antibiotic therapy in acute hematogenous osteomyelitis for 3 months old and older patients. In presumed acute hematogenous osteomyelitis, in a stable patient with a plan to get a tissue culture as soon as possible, please hold the antibiotics until after the tissue culture are obtained. Then choices involve oxacillin or cefazolin in communities with less than 10% of community-acquired methicillin-resistant Staph aureus (MRSA). If there is a communities with more than 10% of community-acquired methicillin-resistant Staph aureus and clindamycin-resistant less than 25%, in communities with more than 10% community-acquired MRSA and clindamycin-resistant more than 25%, vancomycin is selected. For unstable patient, please start antibiotic as soon as possible even without the culture. Please remember that acute hematogenous osteomyelitis may mimic other diseases. The differential diagnosis for acute hematogenous osteomyelitis involve cellulitis, subcutaneous abscess, fractures, transient synovitis, and bone tumors. In newborn and infants in whom osteomyelitis may present as pseudoparalysis, also consider CNS disease, example poliomyelitis, cerebral hemorrhage, trauma, and or child abuse. The diagnosis of acute hematogenous osteomyelitis requires 2 of the 4 following criteria. Purulent material on aspiration of affected bone, positive findings of bone tissue or blood culture, localized classic physical findings of bony tenderness with overlying soft tissue erythema or edema, positive radiological imaging study. I just briefly discussed the questions during my final exam. What is the difference between osteomyelitis in children and adults? Osteomyelitis in children is generally of hematogenous in origin. It is most often acute onset. The primary contributing factor with respect to the prevalence of the hematogenous route of infection is the nature of the endosteal blood supply in the growing bones of children. Another question. Regarding or what's your opinion regarding osteoperforation? Please remember the 2 main indications for surgery in acute hematogenous osteomyelitis is 1. The presence of an abscess requiring drainage. 2. Failure of the patient to improve or respond despite appropriate intravenous antibiotic treatment around 24 to 48 hours. The objective of surgery is to drain any abscess cavity and remove all the non-viable or necrotic tissue. When a subperiosteal abscess is found, several small holes should be drilled through the cortex into the medullary canal. This procedure is called an osteoperforation. In osteoperforation, the pathological site is approached, especially the metaphysis or metaphyseal region where the pus frequently originates. Drill 2 or 3 small holes in the cortex over the metaphysis. In an early case, the pus will stream out of the bone. In an advanced case, the pus has already escaped and may need to drain subperiosteally along the whole shaft. You need to break down any loculi so that the pus can drain freely. Yes, we have reached to the end of this video. See you in the next one. Take care and bye.